2006. At that time, a large distal carious lesion on her maxillary second premolar was treated. Note that a mesio-occlusal amalgam restoration was present on the first molar, with a crack visible on the distal marginal ridge. Note the large occlusal wear facets. It is evident that heavy occlusion, combined with the stress induced by amalgam during thermal fluctuations, are responsible for the crack. The tooth was asymptomatic and responded to thermal tests within normal limits. In 2016, 10 years later, she presented declaring sensitivity to cold stimuli and pain to chewing caused by her maxillary first molar. No episodes of spontaneous pain were reported, and the tooth gave slightly exaggerated responses to sensitivity tests. The crack on the distal ridge was more evident. Removal of the amalgam restoration to explore the cavity floor was recommended. The patient declined. She returned in 2019, after another 3 years, declaring that sensitivity to cold was occasional, but it had recently worsened. She declared that in few occasions, while chewing, she had a sharp pain lasting few seconds. No spontaneous pain was declared. A radiograph taken at this time showed a radiolucency on the palatal root. Sensitivity tests, particularly the cold test, gave a slightly exaggerated response. The pain ceased few seconds after removal of the stimulus. The patient was informed that, despite the equivocal symptoms, the periapical radiolucency is indicative of partial pulp necrosis, for which reason removal of the restoration and exploration of the cavity were necessary, followed by root canal treatment. The patient postponed any treatments. She returned again in May 2020 with the request to start treatments because sensitivity to cold and to chewing had worsened, but without episodes of spontaneous pain. No pain to lateral and vertical percussion. A new radiograph showed that the radiolucency on the palatal root had slightly increased. Surprisingly, sensitivity tests gave only slightly exaggerated responses at this moment. Visual inspection showed that an evident crack line was present on the palatal aspect and that amalgam was no longer adapted to the palatal cusp. In conclusion, the crack on the distal ridge has been present for at least 14 years, and a new crack appeared on the palatal aspect. An impression was taken to store the existing crown anatomy. After anesthesia, the tooth was isolated and the restorative materials removed. During this procedure, the palatal cusp fractured, and analysis of the fractured surface demonstrated that the cusp was flexing while chewing. A crack line extending from the palatal surface to the pulp chamber floor was evident. Treatment plan encompassed root canal treatment and a metal-free crown. After removal of the roof, the chamber appeared largely filled by a voluminous pulp stone. This was removed with ultrasonic tips. Partly disintegrated bleeding pulp tissue was present in the chamber. The prepared canals were medicated with calcium hydroxide mixed with sterile saline to a creamy consistency. A week later, the canals were filled with a bioceramic sealer and single cones. Note the distal crack in the dentin, apparently not extending to the pulp chamber. Given the extent of the pulp chamber, no intracanal posts were placed and the build-up was accomplished with composite materials. Minimal preparation of the residual tooth structure was performed, with the finish line placed supragingivally. Impression with polyether materials. Shade selection. Was adhesively cemented under strict isolation. Occlusion was meticulously checked. Only one occlusal contact was given to the crown in the absence of any working and non-working side interferences. A follow-up radiograph taken after 1 year, showed that the periapical lesion on the palatal root had healed with the image of a lamina dura along the entire apical profile. The tooth was comfortable. The crown and the surrounding tissues were in good clinical conditions. Pulp tissue from the palatal canal was extracted in one piece and was processed for histology. Sections stained with hematoxylin and eosin revealed that the pulp was largely calcified, with only few islands of soft connective tissue. This tissue was infiltrated by chronic inflammatory cells. Bacterial stain revealed absence of bacteria at any level of the palatal pulp. Biological considerations. The role of the crack in the pulp disease process. All crack lines are routes of bacterial entry. In cracks limited to the dentin thickness, a large number of dentinal tubules are colonized by bacteria, particularly in those cracks interrupting tubules at 90-degree angle. The pulpal areas where the involved tubules end show inflammatory cell accumulations. When the crack exposes the pulp chamber, the reactions are more severe and partial necrosis can be observed. The condition successfully treated in the present case is exemplified in this molar. The maxillary molar had caused pain symptoms, and the radiograph showed a radiolucency on the palatal root. Removal of the restoration disclosed a crack line. Root canal treatment was scheduled, but the patient requested extraction. Histologic analysis showed that the crack had exposed the pulp chamber, where partial pulp necrosis was observed. Concentration of acute inflammatory cells were present in the pulp chamber. Lots of bacteria were present in the crack. Vital inflamed pulp tissue was observed in the palatal root, continuous with the periapical inflammatory reaction. Resorption lacunae were present in the dentinal walls, exhibiting multinucleated resorbing cells. Biological considerations. A radiographically visible periapical radiolucency appears at an early stage of the pulp degeneration process, when the radicular pulp tissue is vital. These observations reflect the condition of the molar treated in this report.